Welcome to the Academic Life in Emergency Medicine, Journal of Graduate Medical Education, Hot Topics in Medical Education. That's a mouthful, but we have a lot to discuss today. We're talking about thriving, not just surviving, in residency education. Our topic is the idea of wellness, and what does that mean to you? We have an all-star group of experts, and we're going to be talking about a new paper hot off the presses from JGME. Let's introduce our guest experts and our panelists. I want to turn first to Kristin Raj. Kristin, why don't you say hello, tell us who you are, and what's your interest in wellness in medical education?
Hi everyone, I am a clinical instructor at Stanford in psychiatry and wrote this paper and have been very interested in thinking about resident wellness, how we can make improvements in it, study it, and also working with residents individually to help them with their wellness.
So if you're wondering where to find this paper, it's free access. Go to the Academic Life in Emergency Medicine, ALIEM.com site, and you can get the link to get the paper for free. So joining Kristin, who's the author of our systematic review, we have three guest experts, Arlene, Chris, and Nicole. Tell us about yourself.
Well, hi everyone. I'm really excited to be here. My name's Arlene. I am an assistant program director at the Mount Sinai Emergency Medicine Residency Program in New York City. I'm also heavily involved in several national wellness organizations, including bodies like CORD and ACEP, and of course the think tank. And my interest in wellness actually started when I was a resident, and I felt like it was a topic that was so all-encompassing and sort of touching on every part of our lives as residents, but was not really being addressed at the time.
Hi, everybody. My name is Christopher Doty, and I am the program director at the University of Kentucky. I'm also the vice chair of education. I'm a career educator in emergency medicine. I've been a program director for about 15 years. My interest in wellness actually was sort of sudden. I realized that while I spent a lot of time teaching a lot of different things about emergency medicine, I didn't spend a lot of time teaching about burnout and about depression and stress, something that affects about 60% of our trainees. So after a catastrophic loss in my residency a little bit over a year ago, I completely did a 180, and this is now my professional focus.
Hi guys, I'm Nicole Battaglioli. I'm a new faculty member at the Mayo Clinic, and my involvement and interest in wellness also started as a resident when I started to have my own issues with burnout and wellness. And I felt like as a whole, this is a topic that we can do better with, and we can really do a better job in educating our residents and giving them the skills that they need to have a really nice, long, and healthy career.
And I'm Jonathan Sherbino. I'm an emergency physician in Canada at McMaster University. I'm currently the chair for the specialty committee for the Royal College. To translate that to our American audience and to our international audience, I'm basically the chair of the board for emergency medicine. We're currently changing all the criteria and the design for all of our residency programs in Canada. And we've intentionally included wellness as an element that's required to be taught and a standard for accreditation for our programs. So we're trying to figure out how to make that a reality. So let me set the stage a little bit before we jump into this idea of wellness. We certainly know from a lot of demographic information from international, from national, and from large studies that wellness is affecting trainees, and it's affecting trainees in a new and emerging way. In emergency medicine, specifically as a discipline, we routinely rank first or second, and it's not a place where you want to be the winner in terms of a specialty susceptible or experiencing burnout. But the number that I repeatedly share with colleagues when I try to make it a point about how important wellness is for our current generation and for future generations of trainees is this. In the US, every year, 400 physicians commit suicide. That's the equivalent of losing an entire medical school, all 4 years, every year. We can't continue. We need to do something to change this. And so enter Kristin Raj, who has done a systematic review looking at the literature for the idea of what is wellness? How do we promote wellness? And how do we protect our trainees from this idea of burnout and from mental illness associated with the stressors of the profession of medicine? So we've posed 4 questions to the internets this week, and we'll continue to hear your conversations. You can join our conversation following the hashtag JGME Scholar, or going to the blog and posting there. The questions we want to focus on are 4. Let me turn to the first one, and I want to pose it to Kristin. Your systematic review identified a lot of operational features, features related to physical well-being, features related to psychological and emotional resilience. How do we define wellness? How do we get behind the features that are correlated with it and understand the construct? What does wellness mean?
I think that's a really good question, and I wondered about a lot of places to really find the answer to that, and going directly to the well-being research that goes beyond the medical field was really useful to me. And there in that research, they define it as a sense of life satisfaction, feeling that you're living in accordance with your values, feeling fully engaged with life. I really like that definition because it goes beyond thinking about wellness as just not being burnt out, or instead thinking about what are the positive aspects, what are the things that we want from life. And then correlated with those things, they found that autonomy, competence, and social relatedness were very key features that when those things were met, people had greater wellness. And when I talk to residents about that, they always kind of perk up because they realize that those are major areas in which they often have a lot of deficiencies in what's going on for their lives. It's hard to have a lot of autonomy when you're a resident. It's hard to feel really competent in what you're doing when you're a resident. And social relatedness can be really hard when you don't have enough time for your friends and colleagues to really get to know them, get to spend time with them. So looking at those areas and thinking about ways in which those can be impacted to improve wellness, I think are really important.
Chris, what do you think? Do you have a definition that you use when you think around wellness?
Sorry. Yeah, I historically, the ACGME has always thought about wellness before really this year as just physician fatigue and mitigation of fatigue. And I think we're now much more aware, at least in emergency medicine, of how there are a bunch of other things that we really haven't paid much attention to. So for me, wellness has a lot to do with sort of what Kristin said, living consistent to your values and feeling like you're connected to the people around you, and also feeling like you're having an impact in the world. I think a sense of purpose is tremendously important in wellness. And then, of course, the obvious bit of physical stuff, like having shifts that progress in a natural way, being able to focus on nutrition and exercise and what I call these immunizations for depression, like social connectivity, adequate sleep, adequate time, for mental downtime, that sort of stuff.
Arlene, there's a number of factors that they talked about in this manuscript, this systematic review, that correlate well. Some of them are around physical, as Chris just talked about. They also get to the idea of autonomy, of competence in practice, of your social relatedness and your interpersonal relationships, perseverance or resilience, or whether you're an empathic person and whether that's protective. In your experience, you've survived residency, as we all, and perhaps like all of us, just barely survived residency. What are the factors that stand out for you, and what are the factors that you emphasize for your trainees?
One of the things I really liked about this paper was its sort of very clear identification of these factors, because I really do feel like we're at the stage where we're still trying to figure out exactly how to define wellness. And one of the strengths of this paper was that it defines it in so many of those clear categories. In reading this and thinking about my own experience, I really liked the psychology concept of wellness being related to autonomy, competence, and social relatedness, and how those factors interacted with each other to create either a sense of stress or a sense of overall well-being. One of the things I do struggle with, though, when it comes to defining wellness and looking at the different factors, is that, for example, on the flip side, burnout has been defined solely within sort of the work environment and as it relates to work. And so you can't really use the MBI outside of the work context. Should we, in looking at physician wellness on the other end of the spectrum, also sort of limit our view into things that are work related and things that we as medical educators have more control over, or are we responsible for the residents' sort of total well-being? And I don't know if I have an easy answer to that.
I'll look to our experts. Is there an answer to that question that Arlene puts to us?
I think we're still figuring it out. You know, a lot of this is a moving target, and I think as the paper sort of alludes to, what may be helpful for one person or one group may be very different for another. I do think that a lot of resiliency is not necessarily in what happens to you, but how you respond to what happens to you. And the way that you perceive stress or challenge adds to your resiliency.
I agree. I think there are some personal factors, but there's also some systems-based factors that we need to look at and to address. Building resiliency and some of the things that we can do for ourselves, you know, with positive psychology, performance psychology, and just building our own individual defense and promoting individual resiliency. That's one thing. But I agree with Arlene that I liked some of the factors and thought a lot about some of the factors outlined in the paper regarding competence and a feeling of personal accomplishment. And sometimes that's a systems-based, you know, issue where, you know, we need to recognize our residents for the hard work that they put in and really give them a sense of responsibility and a sense of accomplishment.
I'm from McMaster, so I have this contractual obligation to talk about evidence-based medicine every time I'm in some public forum. So before we get to what are the outcomes or what are the practical applications of your research, Kristin, it's curious to me that you, maybe in an ironic fashion, took on a very momentous task of searching the literature, and you did it all by yourself. So tell us a little bit, what was the rationale about it being a single investigator for a systematic review? I think this might be the first time I've seen that. And did you feel well at the end?
That's a really good question. I think it was born out of me being a senior resident when I started taking it on and was very ambitious about doing it. And I think I saw a systematic review by one author on resident burnout. And so I thought, hey, I think I could do this. It was a little naive, but that was the direction that started in.
Well, I've done a few systematic reviews, and I think you start naive, and and very quickly reality catches up to you, understanding the momentous task. Chris, Arlene, or Nicole, any concerns that maybe the findings here are not as representative as we might imagine in the literature? Does one person's perspective introduce bias that we should be concerned for?
I mean, I do think it is a pretty good question, and you'll do your McMaster colleagues, you know, proud by even asking that. Whenever one person is looking at a bunch of studies, they have complete control over what goes in. And with systematic reviews or meta-analyses, the answer you get depends on what inputs you had. So I do think that these were adequately addressed in limitations section of the paper, but I think that's an issue. If Kristin felt like one thing was more relevant or less relevant, or it was more focused on duty hours, then that may have dropped out from those 50 or so articles that she really got into and not into the core 26 that actually made it into the analysis. So I think what could have improved it was having somebody else to look and decide at those 50 articles or even at the larger number and decide. But again, I mean, this was adequately addressed as a limitation.
I hear a comment from Twitter that's coming across my feed, which is perhaps our current model of peer review, where it is just at the journal level, is being supplemented with this idea of post-publication review. And that's really what we've been doing in this virtual journal club. So we've had an opportunity to say, hey, does this selection of articles into the systematic review seem to make sense? And I'm not sure if anyone else has seen anything, but so far there's been no concerns, more endorsement for some of the concepts and the ideas that have been unpacked there. But I'll look to our audience to comment and say, is there a paper that's been missed, or is there a concept that's been overrepresented? So that's an idea for all of us to pay attention to. Let's turn to what I think probably drove most of us to spend some time on our day talking about this and time throughout the week discussing this, is all of our institutions have formalized programs, typically a standard of accreditation, for which a trainee in difficulty may access support as they go through that process of struggling with burnout, of seeing the flip side of wellness, which is problems in the physical, emotional, psychological, or spiritual realms. But your studies suggested that there's a stigma with accessing these programs. How did that stigma manifest itself in the literature, Kristin? And then to others, how can we break down this barrier so that people can start to access help and start to feel well again?
There was a study done where they had an intervention to have wellness programs be available for people who wanted to seek out help, often mental health help. And they also surveyed those people who came, didn't come, and asked them what was going on, why didn't they come? And some people felt like the program might not be effective. Some people felt like they wouldn't have time. Some people felt like they were worried about confidentiality. So I think that's a really important paper to think about in terms of what can we change there so that people can feel more free to access these services that we want to provide them. And also on the individual level, how do we help people in their individual conversations with friends, colleagues, begin to feel like this is an okay thing to talk about. We want to support each other in this.
I'm going to turn to our experts to see of how we can start to break down these barriers, but I just want to point out a demographic that was particularly bothersome to me, in that women under the age of 32 who were Caucasian had the lowest percentage of accessing these formalized programs. Minorities had the greatest concern around confidentiality, and men questioned the utility of these. So we see these demographic trends which are concerning. So Chris, Arlene, how do we ensure that our trainees are not victims of stigma and then can get the help that will benefit them in training?
So at the risk of repeating myself, as I've said before on the blog and in some recent podcasts, I think that it is incumbent upon the leadership in emergency medicine, program directors, senior faculty, many of the people on our call here, to normalize the conversation around stress and feeling inadequate in our everyday practice. I think that these things are an occupational hazard for what we do, and often we feel like we cannot share that with other people. So I think if the leaders would come out and talk about how they have stress, how they occasionally feel like a bad doctor, how, when they went through their divorce or episode of depression or whatever, about how these feelings, were common in them, then you begin to see, oh my goodness, look, Dr. Smith had this too, and Dr. Smith's a great doctor and a full professor and also on the board of SAEM. Wow, if it can happen to them, it can happen to everybody. So I think that beginning to normalize that conversation is key as a first step.
I totally agree with you, Chris. A lot of this is about addressing the hidden curriculum of medicine and sort of the culture that all of us grew up in, and that was probably going on for decades and decades, which is going to be a long process, but I think we're certainly making good steps towards getting there. One of the things that I always think about as far as decreasing the stigma or increasing the access to mental health programs is maybe implementing some type of opt-out rather than opt-in type of programs, in which, in addition to getting annual sort of physical assessments, residents are also required to get an annual sort of psychological checkup as well. And certainly that would, in my mind, do a lot towards decreasing the stigma and opening up the conversations.
So let's talk about what we're doing. Kristin, your systematic review identified 3 interventions. As you articulate, they're all small, and so I don't think we can draw sweeping conclusions and wholesale adoption of them. They're the idea of making gym access freely available, having a regular faculty consult around goals and finding out professional development for trainees, and then a coping mechanism intervention so that people could start to develop a toolkit to promote resiliency. I guess I'm more interested in hearing from yourself, from our expert panels, about what do you actually use in your program and how's it working? Or if you had an ideal world where you could have the best wellness program, what would you build?
Oh, I love this question. So we do multiple things at Stanford over various programs, and that's why I think in particular having a few studies that have been published about this, that's good, but there are hundreds of programs out there that I know every program in the country is thinking about wellness in some way, and there are many interventions there at many institutions. So what I would love to see happen is some kind of centralized website, a place where we can all join in and say what we're doing, say what's working, what's not working with our programs and the wellness interventions we're trying, and then be able to build from that. I think a lot of us are trying to reinvent the wheel for our program, think of something that might be suited for us, and we learn things along the way with that. But if we could all learn along the way from everyone together in a more centralized location, a website, people join in and have a conversation about that, I would love to see that happen.
Oh my God,
Arlene?
Kristin, I totally, like, I wish that website existed, because, you know, sort of in my position, as I've been lucky enough to be part of several different organizations all looking at wellness, so many of the different groups are sort of reinventing the wheel. And if we could all just kind of pool our efforts together, we'd be that much stronger.
Right.
I think one of the, you know, I think we're all headed toward an answer, although as has been brought up earlier on Twitter, I think that, you know, a bunch of the data so far has really been looking at problem identification, and we're certainly a little bit weaker as far as interventions going forward. And I'm almost feeling like we're at the point where it is almost time to shift our focus towards looking at programs. Are they working? What parts of them are working, and which parts can be stronger?
That brings up an interesting question, and that question is, how do we really measure wellness? I think when we look at the different surveys and inventories and measurements that are out there, they measure one specific thing, and that creates an issue. You can measure on a depression scale, or you can measure on a sleepiness scale, or you can measure some sort of physical wellness, but we really don't have anything that measures all 8 or 9 or 12 or how many ever you believe spokes on the wellness wheel.
Nicole, final thoughts from you before we wrap up.
I think that one thing that came out of this paper for me is it just really pointed out the paucity of literature and information that we have about what works and what is actually making a difference when we are talking about wellness and these different interventions. So in the future, I'd love to see more studies done about specific interventions and really trying to pin down and figure out what's going to work and what's not going to work. But I really enjoyed the review of the literature because I felt like it identified some good factors that are negative and positive for wellness, but it also identified areas where we can really improve the research and really look at some things, you know, to kind of help propel this mission forward and really help find some interventions that we can use for everybody and that might actually make a big difference.
Well, our time is nearly over, but before we go, I just wanted to give an opportunity to our author and to our experts. Are there any final words that you want to leave our audience with before we sign out? Here's my final word. I think what I've heard pretty loud and clear is that we're starting to get an idea of what wellness is. And I think we're certainly, unfortunately, sadly aware of the impact of having unhealthy or burnt out physicians in our midst. What I think we all want to do is prevent reinvention of the wheel, because development of curricula are challenging. So this is a call to all of you who are watching or listening. Share with us your intervention. We'd love to develop a clearinghouse as part of this virtual journal club so that we can share what you're doing, brag a little bit. Send us a link to what your curriculum or your intervention looks like, so that for those of us who are in the early stages of developing something, we can look to what you have, modify it for our local context, and then potentially have an influence that stretches beyond what you developed at your home program. So you can find us, share us what you have, and you can find us at the hashtag JGME-Scholar, or come to the Academic Life and Emergency Medicine website. That's ALIEM.com. Well, that's it for us for now. You can continue to join in the virtual journal club. We want to hear what you thought. For those of you who are watching this on delayed stream, we'll be interested to hear your comments. We'll be around all week and responding to your. Thanks so much for listening. Take care.